I want to kind of move towards, in our last few minutes, talking a little bit about other agents. We've talked about a couple that are farther along in the either approved or farther along in the regulatory review process. But I remain struck by the number of agents that continue to be studied. You might think that we've reached our limit, so to speak, in immunotherapies and antibody-based therapies, but there are bispecific antibodies, a number of them, and there are versions of bispecific antibodies where different technologies or different companies have engineered their own version of a bispecific or new type of antibody. We have antibody-drug conjugates. We have the bispecific T-cell engager and blinatumomab, which is approved in certain settings. How do you think about, first, before we get to other categories of drugs that you're excited about, of these kind of novel immunotherapies, for lack of a better term? And I'll ask Matt to go first, and then Cami, and then Nathan as to your thoughts on where these fit, because some of them have had data that, particularly I would say both the antibody drug conjugates and the bispecifics, that are kind of approaching or even better than some of the things we talked about today. So Matt, your thoughts?
Yeah, so I think that, some of the bispecifics, like glofitamab, which has 2 different binding domains, I believe, to, CD20 that then, engage CD3. And then you have, it's always fun trying to learn the new names. Epcoritamab, which is a sub-Q bite, kind of going after the same space. It's really going to kind of be generating data, but not a lot of the data is going to follow CAR T. So we're going to kind of get response rates and PFS, but there aren't going to be in the population potentially where you may kind of enter the playing field a little bit here. But I think it's great to have the data, because if you don't have data there, you're not going to want to go into those populations. So I'm excited about seeing that those drugs kind of get longer follow-up. We've got their overall response rates, but and CR rates, but we need durability.
Cami, your thoughts?
Yeah, so there's still some good data out there. I think there's 3 CD19 ADCs that have been developed, the antibody drug conjugates, all showing pretty similar responses. However, 2 are not going to be further developed because of toxicity. The third one, good responses. The responses don't last long, and it's probably going to have to be in combination, kind of like some of the other agents we talked about today, to really get good remissions, if you're going to see those good remissions. I think the bispecifics are interesting. There's a few of those have been looked at in the post-CAR T setting and have activity there, which is probably one of the highest unmet needs, is those patients who are post-CAR T.
I think mosunetuzumab had a couple of post-CAR T, patients on it, if I remember the data correctly.
Yeah, from the ASH 2019 plenary, yeah.
Yeah, that one, and then the Regeneron one just recently put out data with some responses post-CAR T. So, potential therapies like the selinexor to offer those patients.
At least it shows that they're listening to us, because, a lot of trials have been trying to write off patients, post, not allowing prior exposure to CD19 CARs. It's like, why? Like, why are you doing that? That's exactly who we should be studying. Yes, create an expansion cohort for all you want, and analyze the data differently, but we need to understand that population.
Nathan, your thoughts on some of these new drugs?
Yeah, I will echo what everyone said already. I think when we were looking at the BiTE molecules a couple of years ago, there was some sense that maybe they would displace CAR Ts. But a lot of the data that we're seeing now as it matures, I don't think that the durable CR rate appears to be at the same level that we're seeing with CAR T cells, at least in large cell lymphoma. So I don't see that those things will replace CAR Ts, but I agree with Cami and Matt that they probably will follow CAR T as a salvage for these patients. The other thing I thought at this most recent ASH or ASCO, there was a nice abstract on allo CAR T, and I think that's something that I think would be very interesting to develop a kind of off-the-shelf strategy for CAR T, where you would have something that's kind of sitting in your blood bank and be able to give patients when they relapse. So, but those studies are still very small, but that I think that would be something we should consider more.
So Matt, you've talked about the access and applicability of CAR T. I mean, it strikes me that there's a large percentage of people who could benefit from CAR T that are not getting them. And it strikes me that having new agents around is going to make that number getting CAR T even smaller, because people are going to have alternatives, and whether or not they're appropriate or not, it's obviously good for patients to have alternatives. But the fact is that people will be more inclined to say, well, it used to be, well, you got to go get CAR T. And now the discussion will be, well, you can get you probably should get CAR T, but you could get this or you could get that. What do you think? How do you think that's going to change the big picture?
Well, I still have a lot of hair to pull out over in my career. So, but I think it just comes back to, I want to be a resource to have, or I think we all want to be a resource to have those discussions in this population on who's appropriate to go to CAR T cell and who isn't. And it's great that we're getting all of these new classes, more drugs to have the discussions about, but really it's a chess match. It's a chess match against large cell lymphoma, and knowing what piece to play next. And, you may be moving one piece to make a move, three times down the road, and that may be CAR T cell, because that's what the data shows. But we have to continue to encourage that if you're doing a CAR T cell study, you should be able to get a CD19 BiTE, or you should be able to get a CD19 antibody before the CAR T cell, so that we know, so we can inform the patients around this, not exclude the patients from the studies, and then they can't get a CAR T cell or the next generation CAR T cell, because that may be the patient population that does derive benefit.
So Cameron, you at Ohio State clearly have lots of access to CAR T, but yet you've been participating in a variety of different trials, including some of the agents we've talked about today, which in some ways tells me that you see excitement and promise in some of the things that are not CAR Ts that we've talked about. How do you, that they're fulfilling or potentially filling a need for your patients? Why do you think that is, from the standpoint of just ease, toxicity? You could put all your relapsed large cell patients into a CAR T commercial, or and I'm putting you on the spot here a little bit, but I just want to see how you can think about how people in practice should think about this. Clearly going on a trial with tafasitamab offered something to those patients that was attractive. So, how do you think about it? Because I think it's the same way people are going to have to think about it in practice.
Yeah, I think looking at your patient, what are they able to tolerate? If something is very well tolerated and they can get a good response from it, I think access, obviously they have to come to us for the trial, but just in general, when you look at Ohio serves a big population. There's a lot of land here for a small amount of people, so we serve a number of states, and when you're looking at making recommendations for therapy, not everybody can travel to get access to the big center. Not everybody can wait to have their CAR T cell sent off and manufactured and returned and not get therapy in between that time. Sometimes it's still an insurance issue or a financial issue. You have to be able to have the coverage, pay over what isn't covered. You have to stay within, a certain closeness to Ohio State for a certain amount of time after you leave the hospital. And all those represent challenges for our population in this area.